Yeah, assalamu alaikum and good afternoon. My name is Hans Kedzierski. I'm from the Netherlands and I'm a hospital manager or CEO for the last 35 years. And I think the 5 most interesting years spent was at AKU in Karachi because it was a new culture for me. It was challenging, but it was also a good learning experience for me, and it made me also a little bit more humble to understand how it is to manage big institutions that face huge challenges. Today I'm speaking to you as the representative of Novacare Hospital in Islamabad, which actually does not exist yet. We are in the phase of constructing it, and we plan to see the first patient in December 2026. Let me see how this works. Yeah. So today I will try to give you just in 2 minutes time an introduction of this hospital. We are a new kid on the block. Nobody knows us, so I'll tell you a little bit what we want to be. And then talking about the future, I thought it might be interesting first to have a look at the history, to understand, okay, where we are today, and when we understand where we come from, it might help us to address the challenges that we face ahead. Then I will talk some trends, which actually already discussed by Professor Adams and Irfan, so I will go through that rather quick. And I think I will mainly focus on the key risks from all these trends when they become uncontrolled. And then I will focus a little bit, okay, what does this have for implications on Pakistan, and how should Pakistan organizations try to address this? So this is a rendering of the hospital. As mentioned, it's a new hospital. We try to make it a unique facility. These are some key figures. It will have approximately 250 beds. It will be able to expand to 450 beds in another phase. There will be sufficient clinics. We also will have some clinics outside the hospital as feeders, but also to reach out. So this presentation will also be published on the website of the organization. So whenever you want, you can have a look at it further. As some of you might suspect, we will work not with the classical departmental organization structure. We will work with what we call today integrated practice units. And let me give you an example why we want to do that. If you are a cardiac patient, you want to go through a typical journey where every specific knowledge and skill is centered around you. So when we look at cardiology, interventional cardiology specifically, interventional cardiology was invented to make cardiac surgery redundant. That was the dream of the first interventional cardiologists 25 years ago. And they went through a tremendous journey. They had tremendous success. But unfortunately for them, cardiac surgery is still there. But cardiac surgery has changed. It has become minimally invasive. So more and more the question now is, what exactly is the principal difference between interventional cardiology and minimally invasive cardiac surgery? And I don't want patients to struggle between options. I want to bring all these specialties together to make sure that we offer the best possible service to any patient who goes through this cardiac journey. So we will bring together medical and surgical specialties based on what is a typical patient journey through the organization. I think a very important asset for us is that we established a clinical partnership with an outstanding NHS trust, the Imperial College Healthcare Trust in London, and they will provide us with multiple moments of assistance, of support, They will do regular surveys. We will organize second opinions. We will organize observerships. And the main reason is that through this, we want to establish a culture of compliance with best practices in our hospital in Islamabad. And also by doing that, giving an impulse for a discussion in the country how to altogether meet higher standards. So we're very proud of that. And I can tell you, it is challenging. Because, for example, last week we closed a first document on the scope of radiology. And then we have a discussion with the radiology specialists in London, and they ask so many questions. We said, okay, thank you very much for the input. We will review our document again. So it helps us really to focus on these quality aspects that I feel are very important, and that also will create a working environment for our professionals to become the best. So I leave this for now what it is. Now, back to the trends of the future, starting in the history. One of the first hospitals in Europe is this beautiful building, it's a museum nowadays, is the Hospice de Beaune. It was the first built hospital in France and actually in the whole of Europe. And it was the beginning of centralization, because before that, medicine was actually practiced by quacks on markets, and everybody was, doing whatever magic trick he could offer to the public and would consume it. So slowly, over the centuries, these hospitals emerged and tried to professionalize these behaviors and these practices. A similar trend was in the Islamic world. This is an example of a hospital in Damascus, one of the first Islamic institutions that tried to bring together under one roof professionals, and actually that was the beginning of the building of medical science. So the trend was centralization, and for centuries we have put billions of dollars in these humongous institutions, hospitals, because we thought that's better, it's cheaper, and we need to bring together all the skills and knowledge under one roof. It has its side effects, because it becomes a world in itself, and it becomes very expensive. And to counter that, most Western countries have their primary healthcare systems to make sure that not everybody just walks in and consumes the very costly, highly specialized services. But the thing is that we are all raised professionally in institutions that think it's all about us. And this now is changing. So a trend of centuries, mainly through the introduction of new technologies, is slowly turning in the other direction. So we observe a combination of trends, which we will discuss later on. Keep in mind, we are not happy with change. I think that's the bottom line here in discussions when we talk about quality and future policies and strategies. Making change happen in our institutions is extremely difficult. And I think one of the reasons is this century-long putting emphasis on it's all about us. So, what are these trends? And I go quickly through them because we have heard them already. We talk today about hospitals without walls. We will be more community-based. We will be more virtual. Professor Adams has rightly pointed that out. We will have wearables. There will be real-time monitoring. And of course, hospitals still will be the center, but more and more will be happening outside. And imagine that as managers of a hospital, that most of your services are not more happening in your hospital, but somewhere outside. The other thing is the whole data thing. We have more interoperable data systems. The magic word is, of course, artificial intelligence. I think 6-7 years ago, I've attended the MRSNA in Chicago, the annual conference of radiologists, and every discussion was on, oh, AI, it will make our jobs redundant. And as a joke, I said to one of them, yeah, hopefully, because that makes our life a little bit more simple. Actually, it's turning in a different direction. It's becoming more helpful. And again, it's an issue of managing to adapt professionals to integrating new technologies in a new way of doing their job. I will not repeat what I already said. Now, this is an interesting thing. There was news lately that a Chinese hospital, completely virtual, and 14 AI doctors or systems, I don't know how you would call it, are able to manage 3,000 patients in a time that nobody would imagine. So the machine, based on data, can produce results and advice and further treatment in a way that humans could never repeat. Now, is this something that can help us? We'll see. The other thing is robots. Of course, pharmacy robots we know since a long time. We have surgical robots. There are now robots that can handle patients' emotions. There are housekeeping robots that can clean your washrooms and clean your premises. Can I have some water, please? There are distribution robots, service, anyway. So it's going to happen. And last week, the autonomous cyber cab was produced, which is an extreme example of a good robot. It was already mentioned, personalized medicine. Thank you. Sorry. Yeah, that helps. Patient empowerment, that was already mentioned, that is very important. There was talk about bottom line and quality. I never talked with clinicians about money. Yeah, once a year when it comes to establishing the budget. We talk mainly about quality. And more specifically, what I learned over the last many years, clinical outcomes. Of course, JCI accreditation is important because it helps you to follow certain practices. But the real incentive for the primary care delivery to think about quality is to compare their clinical outcomes with that of their peers. So imagine a group of surgeons compare based on agreed indicators their performance. Could be post-operative infections, readmissions, whatever they agree. And out of that follows a rank order. So imagine you have a practice of 6 surgeons. So surgeon 1, 2, 3, 4, 5, 6 in that order. Imagine you are surgeon number 6. What would you think? The first thing what you think is the data are wrong. But once we have addressed that, the discussion is, okay, what can we do to improve your performance? And that, I believe, is the real approach to create a bottom-up culture to think about quality. And I think that is more important than all the other trends together. Bringing together, because this technology will happen anyway. Whether we like it or not, AI will come, machine learning will come, robots will come, even in Pakistan. It's the way our professionals appreciate all this assistance to help them understand how good am I performing. Because I agree, it doesn't make the doctors redundant. It gives them another type of job. So then the quality of performance is becoming more and more important. I leave that for what it is. So I address a few points that Professor Adam already mentioned. The data tsunami, what if these data come in the wrong hands? So insurance companies should have never access to personalized data because it would give them the opportunity to exclude you for services or increase their premiums drastically. Also, I think governments should not have access to personal data of patients. The robot tsunami is going to happen. We talk about dehumanization. Okay, what if too many robots come in? Where is the human touch? Maybe not that relevant for Pakistan at the moment, but in some Western countries it is. The algorithm risk were already addressed. One false algorithm can do harm to millions of people. There is a very famous example of the Dutch tax system where an algorithm would penalize people that meet certain criteria. And these criteria were wrongly defined, and these people were put into deep, deep, deep misery, with quite a few of them, in the end of the day, committed suicide. And that all because of a certain algorithm had the wrong impact. I think another thing is the clinical reasoning. If you rely too much on AI that based on certain data suggests, okay, then this is the next treatment, and you follow that, the question for training is, where is the clinical reasoning? Let me give you a simple example. There was, and I'll talk about my home country, Netherlands. At a certain point, the community of surgeons decided no patient with a properly indication for appendicitis should be moved on without a CT scan. So that raised the cost tremendously because everybody coming in or might be an appendix need to have a CT scan. It erased completely the physical examination by which normally a physician should have identified, oh, this is an appendicitis and we should do surgery. So there is a risk of changing the nature of thinking of physicians. And I think that's something we should take very serious. Social inequality, as already mentioned, probably the well-to-do will profit more from it than others. Now Pakistan. Whatever we do, still hospitals are needed in Pakistan. But more than that, is needed a more investment in primary health care. And this could be done through technology, through AI. And as I mentioned, virtual and data and AI-driven care can help provide these basic care. Yes, 3 minutes. So keep in mind that example of this Chinese hospital, 14 IT robotic doctors treating 3,000 patients, could be a solution to start offering primary health care to the masses in Pakistan. There is, however, also an education gap, and I think we should work on that. I learned a few weeks ago that 22 million children in Pakistan do not visit normal primary education. So imagine the inequality creating by that. And regulation to prevent the adverse effects of all these trends discussed is required. So technology can replace certain human activities. Another thing is globally in 2030, the shortage of physicians and nurses will be about 10 million professionals. Already 20% of the medical workforce in the UK, US and Canada is from Pakistan or India. So we have an imminent threat of a medical brain drain from Pakistan moving to these countries who can afford better salaries, but also giving better professional opportunities. And I think no technology can work against this. So we should really focus on what can we do to keep all these professionals or more professionals in Pakistan. So what are my conclusions? Technology will come, whether we like it or not. It won't be sooner or later. It will come. Consequences must be studied. Policies should be made in place to avoid harmful effects. There is a risk of dehumanization. Technology is nice, but the human touch, as Irfan also mentioned, should be in place at all times. And again, primary healthcare should be priority number 1, 2, and 3. So that's my 5 cents to this discussion. Thank you very much.